Good afternoon, one and all present here. This is Shagnik, the designated moderator from Clearnet for this session. Clearnet is very proud to be a part of this webinar as its digital partner. Now, without further delay, I would like to play a short video of Clearnet. Thank you everyone for their kind patience. As we all know, Clearnet is India's largest live digital CME and doctors generated medical content platform, which is exclusively free for all the medical practitioners. You all are requested to visit our website www.clearnet.com where you can watch lots of live sessions conducted by doctors with great expertise all across the globe. We also have MedWiki service, which is a medical Wikipedia, which is exclusive for the doctors to read as well. We are very grateful to this association and the star-studded panel with such highly affiliated doctors to be associated with us. Before we start the session, I'll request everyone that when the person or a speaker is presenting his or her presentation, keep yourselves muted apart from the person giving the presentation for smoother audio streaming. Also, if any faculty member has the virtual stage to speak, I'll request them to keep their video on as well. Now, without wasting any further time, I would like to hand over this session to the Honorary Secretary of NNF Gujarat, Dr. Prashant Karia. Sir, if you may please take the virtual stage.
Thank you so much. On behalf of NNF Gujarat, I, Prashant Karia, the Secretary of NNF Gujarat, welcome one and all to today's Neonatal Pathshala. I request our President, Dr. Dipen Patel, to welcome all.
Thank you, Dr. Prashant Bhai. Good afternoon, dear teachers, colleagues, and dear students. Today is a golden day for Gujarat State NNF that we have with us Dr. Praveen Kumar, who is President of NNF India, who is a great teacher and excellent clinician. I know you, sir, since the year 2006 when we were in first year residency of post-graduation, when you conducted a satellite ventilation workshop for newborns over a period of 4 days in Ahmedabad. So we were mesmerized with the way you taught us. So since then, we are a fan of you, sir. So welcome, sir, for this innovative digital platform. We have Dr. Mohit Sahni, sir, with us, who is a moderator for this program. Dr. Mohit Sahni is also an excellent teacher for us because he has taught us functional echo since year 2011. So welcome, Dr. Mohit Sahni, sir, also. Over to you, Dr. Prashant Bhai, for further proceeding.
Thank you so much. I just request our advisor, Dr. Somsekhar, sir, to welcome all.
Welcome everyone to the Neonatal Pathshala. As Dr. Dipen said, we are grateful to have Dr. Praveen Kumar give us a lecture today on antibiotic therapy, and happy to have Mohit, who started this program a long time back. A reminder to sir, while we see 6-7 people on the screen, most of the people are on a different platform, browser-based platform. So there the audience is much bigger, and many of these videos go on to YouTube later on. So I think with that, I think I'll pass back to Dr. Prashant. Thank you.
So thank you so much. Now, without taking much of a time, I just invite today's moderator, Dr. Mohit Sahni, who is the director of Neonatology Department of Nirmal Children Hospital. He is the editor of NNF Journal, as well as running functional eco workshop. So he's going to moderate today's question. So anybody who is having a question, they can just put on YouTube as well as the ClearNet platform, and we'll be asking to the sir. Today we are having Dr. Praveen Kumar, sir, Central NNF President, with us. He doesn't need as such an introduction, but then just a simple words that sir is a down-to-earth personality, just a phone call away, and without hesitation, when we said, sir, we just want you as a speaker, he said, yes, I'll be coming. So sir is a professor and head of Division of Neonatology Department of Pediatrics, PGI Chandigarh. He is honorary member of American Academy of Pediatric Society and ex-visiting professor, University of Toronto, Canada also. Sir's special interest is in quality improvement and patient safety, healthcare associated infections, retinopathy of prematurity, and neonatal hyperbilirubinemia. He has published many articles in a peer-reviewed journals, papers, and written many chapters in the books also. Sir is the ex-chairman of NNF Evidence-Based Clinical Practice Guidelines for Newborn Care in India, and at present is the president of NNF. So he's going to take a very interesting topic. Everybody is using antibiotics, but they are not having antibiotic stewardship. When to start, which antibiotic to start, what to give, and how, for how many duration to give. So all these queries will be answered by sir. So I request Dr. Praveen Kumar sir to start his presentation. Thank you, sir.
Okay, thank you very much, Dr. Prashant, Dr. Dipin, Dr. Somashekhar, Dr. Mohit, and all the Gujarat NNF team, and the people who have provided this platform, the Clarinet team. So rational antibiotic therapy or antibiotic stewardship, the other name for it, I think it is something close to my heart. And for several years now, I think virtually we talk of it, in every day, every patient, every round we take. And hopefully in this year, NNF would also take this topic in a bigger way and maybe have in a campaign mode. So the basic objective of my discussion today will be to discuss the fundamentals, that what do we mean by rational antibiotic therapy and how all of us can practice it in whatever, setting we may be working, whether it's resource constrained or resourceful. I'm not going to teach you about diagnosis or management of sepsis. It's something, some people may be thinking I'll talk of that. So that is not my goal, although I will touch a bit about the sepsis screen, because that is one of the commonly used bedside tests. So let me begin with the story, which is not, unusual or uncommon. I'm sure if you will read the story, this is something so familiar that every day in, day out, all babies we are doing like that. So a preterm 31-weeker, 1 kg baby born to a mother who has PPROM, absent endosteric flow, so develops tachypnea at birth, which settles within 12 hours, but is on CPAP. And as is the usual practice, get started on first-line antibiotics, piperacillin, amikacin. A blood culture is sent, which is reported sterile. But as would commonly happen in a 31-weeker, at 44 hours of age, baby develops apneas. So antibiotics are upgraded to cefotaxime, amikacin. This time blood culture is not sent somehow, but CRP is done, which is 40, ProCal, which is done 6. And 24 hours later, maybe 34 hours later, at the age of 78 hours, there is some abdominal distension, an X-ray is done which shows dilated bowel loops, and the person who sees the X-ray thinks the bowel loops are thickened. So the antibiotics are upgraded to meropenem and metronidazole. 10 hours later, the baby develops shock, requires intubation, so antibiotic is further upgraded to colistin. Blood culture is sent this time, which is reported sterile. So baby shows some improvement. On day 6, there is some yellowish discharge noted from the umbilicus. So it is thought maybe staphylococcus. So Vanco is added, Nero is stopped. And 2 days later, the baby suddenly crashes. There's a massive pulmonary hemorrhage and dies. So I think this is not an unusual or uncommon story. All of us see this kind of babies. So I want you to think for a moment, what kind of thoughts come to your mind when you read this story? You can type in your own chat box on your own platform. Whatever comes to your mind. I'm not going to discuss what you say, but then just to see that what are your responses, and I maybe once they come on my post, then I will read them for you. But let me begin with a small video. That why should we bother about rational antibiotic therapy? For example, this baby, I gave the example. I'm sure without my speaking, you know why I gave this example. This is a common story. So let us listen to this video for 2 minutes and see why we should be bothered about antibiotics.
Following the discovery of penicillin in 1928, antibiotics have saved millions of lives around the world, and the average life expectancy has increased considerably. But the wealth of these miracle drugs is not only a success story. The bacteria have fought back, and today we see an alarming trend. The number of multi-drug resistant bacteria has grown dramatically over the last decades, resulting in thousands of deaths due to infections that cannot be cured. What happened? The massive use of antibiotics has stimulated bacteria to develop resistance mechanisms in order to survive. For many years, we did not know enough to take this global threat seriously. And although awareness and involvement has increased, much damage has already been done. Antibiotics are often prescribed unnecessarily for infections that are likely to go away without treatment. In many countries, antibiotics are also sold over the counter without a prescription from the doctor. At the same time, in many low-income countries, lack of access to antibiotics actually causes more deaths than resistance. Multi-drug resistant bacteria spread within hospitals as a result of poor infection control, and also between people in the community. Bacteria know no boundaries, and extensive international travel and trade help resistance spread from continent to continent. Antibiotic resistance does not only affect humans, but also the health of animals and the environment. It is all connected. The unpleasant truth is that scientists have not come up with a new class of antibiotics since 1987, and we are about to enter a new era where many commonly used antibiotics have lost their effects. Modern medicine relies on the availability of effective antibiotics. Without them, it would be too risky to perform organ transplants, cancer chemotherapy, or even common surgical procedures such as hip replacements. Care of preterm babies would also be at higher risk for untreatable infections. Resistance is costly, both for the individual and for society. By 2050, the number of deaths due to antibiotic resistance could reach 10 million per year, and thus exceed the number of people who annually die from cancer today. Antibiotic resistance has been considered as dangerous and deadly as terrorism and global warming. Are we heading towards a post-antibiotic era? We cannot reverse this frightening trend, but we can slow it down. And all of us need to change our behavior to once again gain the upper hand in the fight against antibiotic-resistant bacteria.
So let me discuss with you, what are the problems if we use antibiotics irrationally for long periods, or the empirical ones which we often use. So as far as the newborns are concerned, if you look at the evidence, we have definite proof that it will increase the risk of necrotizing enterocolitis. And in fact, people have calculated maybe 4% increase with each additional day of empirical antibiotic. Mortality is increased, length of hospital stay is increased, and then definitely we have increased risk of fungal infection and obviously increased costs. So you can imagine that you are giving antibiotics to save the patient, but actually it is increasing the mortality. And if you can look at more side effects, I'm sure many of you have read recently that once you give antibiotics, the microbiome gets altered and it can stay altered lifelong. And there is a strong association between this alteration in the microbiome and the non-communicable diseases. It has been seen that even a single dose of antibiotic given to the baby after birth can alter the microbiome, which can stay lifelong. And you are very well familiar with these disorders which now have been linked to this alteration of microbiome, whether it's obesity, diabetes, cardiovascular disease, skin disorders, tumors, Alzheimer's, and I think the list is kind of increasing every day and day out. So what do we understand by...
Sir, just a minute. There are so many answers to your question which is there on YouTube as well as ClearNet. People are saying that majority are saying sepsis, NEC. Few are saying high anticipation of sepsis, wrong choice of antibiotics, why to change frequently antibiotics, and last one saying hastily change in antibiotics. What about antifungals, prophylactic or treatment for this baby? So these are the answers of your question.
Excellent, excellent. So I think all of you are so knowledgeable and you have great insight already. So my task will become certainly easier. So what do we understand by rational antibiotic therapy? So basically there are 5 R's. So you choose the right antibiotic for the right patient at the right time and administer in the right dose and through the right route. And basic purpose is that we want to ensure the best patient outcome while causing least harm to the patient as well as future patients. So this cannot be achieved without a multidisciplinary effort and facility-specific effort, because you need the microbiologist, you need the pharmacologist, you need the infection control. So all of the team has to really work together if we want to practice antibiotic stewardship. So what are the types of antibiotic therapy? So basically you can classify into three groups. So one is the most common when we start empirically, when a patient is sick, we think there is possible infection. So pending my reports and investigations, I start antibiotics. That's the empiric. And hopefully I've sent cultures, I'm waiting for the culture reports. If your culture grows a pathogenic organism from a sterile body site, so then we continue the antibiotics, we call it definitive treatment, because now it's a microbiologically confirmed sepsis. And occasionally people give prophylactic antibiotics, especially in the as a surgical prophylaxis, when you're performing major surgical procedures. But otherwise, we are all scared of using prophylactic antibiotics, especially in the medical condition. Now, what is the challenge for the clinician, especially for neonatologists or pediatricians? So if you do not give the antibiotic or give it late, then patient may obviously die or may have many complications. And we have often seen preterm babies where if we do not diagnose sepsis, they straight away manifest with a massive shock or hemorrhage and they die quickly without even, giving us time for giving antibiotics. So that's the challenge. However, if we give unnecessary antibiotics, then also patient may die. I gave you that initial story. The patient still died in spite of giving the best possible antibiotics. But this kind of correlation is not visible. If patient dies, people question you, okay, did you give antibiotic? Did you start in time? Did you give the best antibiotic? But if a patient dies on antibiotics, nobody questions you. Why did you give this? Did the patient die because of antibiotic? Because that association is not easily visualized. So in newborn, we are faced with unique challenges if you want to practice rational therapy. So the problem is the newborn has limited repertoire of signs, and symptoms of signs of sepsis are so non-specific, and virtually they overlap with all other perinatal illnesses. So clinically, to decide that this baby is having sepsis is not so easy. People have given scoring systems, combination of signs and symptoms, but I think none of them have really proven to be, so reliable that we can blindly follow and say, okay, we are confident. And as I said, they can deteriorate rapidly, die suddenly. The other challenge is that although we say send blood cultures, and our microbiology friend will tell us send 2 blood cultures, not 1, in 2 blood culture bottles. So how can we get the blood culture, the volume of blood which we need in small preterm baby, where even to get a vein is so difficult, and to get the adequate volume, and then the number of cultures, and then to collection system. I don't know how all of you collect your blood cultures, but unlike in adults, most of us end up having an open system where the blood is being collected through a broken needle or through a hub and needle. So it is obviously exposed to the environment, increasing the risk of contamination. And unlike adults, we are unable to switch to oral antibiotics after a certain period of time, whereas in adult practice or even pediatric practice, it's easy to switch to oral antibiotics. So these are some challenges in newborn which we have to tackle while we want to practice rationally. So let me give you now some case scenarios, and you can answer in a chat box simply yes or no. So question basically is, should we initiate antibiotics in the given scenario or not? So the first scenario is, you have a 28-weeker, 800-gram baby born by cesarean section because of antepartum hemorrhage. Baby is asymptomatic, but obviously needs to be kept in incubator in the NICU because of prematurity and extremely low birth weight. So would you give antibiotics? Yes or no? You can enter in your chat box.
Sir, people have been writing, some few of them writing no.
Okay, some are writing no. Anybody writing yes? But there's nothing wrong or right. You write what is actual practice, and that is the best way.
No one has written yes, sir, in first scenario.
Great. So I hope this is what you practice also. That's wonderful. Again, a very knowledgeable audience. So a 37-weeker, 3 kg baby with respiratory distress soon after birth, respiratory rate of 70, needs oxygen to maintain saturation, and is born to a mother with spontaneous labor of 3 hours duration, and obviously gets admitted to the NICU. So would you give antibiotics? Yes or no?
So just few additions. Few have written that on first scenario, they will give antibiotics till culture is negative.
Okay. Okay. All right. Yeah. Okay.
Sir,
Yeah.
on our Clearnet website, Dr. Arun has written no.
Okay. Okay. So while people are answering, let me go to the third scenario. So a 30-weeker, 1.2 kg born by cesarean to a mother with severe PIH and oligohydramnios, and has severe respiratory distress at 2 hours of age and needs assisted ventilation, likely to be requiring surfactant also, possibly. So would you give antibiotics to this third baby or no? I'll wait for a few seconds for the answers. So majority is no for scenario 1, majority is no for scenario 2. What about the third one?
Scenario 3.
Yeah, scenario 3, what are the majority of answers?
There are a couple of no's.
Okay. Any yes? Any yes for scenario 3?
Sir, yes, many. For
Many.
scenario
Okay.
3, yes, many.
Okay. So I think I agree with most of you that first 2 babies do not need any antibiotics. The third one, simply because the baby is so sick, even though there is no setting for infection, but baby is so sick that obviously most people would not take a risk and would initiate antibiotics. And then obviously the good practice will be if culture comes sterile, then we should stop quickly. So that is fine if you are starting antibiotics in scenario 3. Okay. 32-weeker, 1.3 kg, born by vaginal delivery, and this time mother has PT prom for 12 hours duration, and baby has tachypnea at 4 hours of life. So antibiotic, yes or no? Scenario 4. So how are the majority of answers?
Yes, one or two yeses are there.
Okay. So here, we have a risk factor that mother has preterm premature rupture of membranes. And if a baby is born through that and is symptomatic and is 32-weeker, then there's no way to rule out infection in this scenario. And definitely the recommendation would be to initiate antibiotics in this kind of scenario until proven otherwise. A 36-weeker, 2.7 kg baby comes on day 3 of life from home, bilirubin of 24, so requires blood exchange transfusion. So would you give antibiotics, yes or no?
All answering on YouTube, please write scenario 5. Yes. So we will come to know. Otherwise, it is mixing up.
Yeah, okay. Scenario 5, yeah. So what are the answers for scenario 5? Yes or no?
2 said yes.
Okay.
1 said prophylactic.
Which is same as yes.
Yeah.
Anybody?
4 yes, 1 no.
Only 1 no. Okay.
Yeah. Almost all yes, 1 no, and 1 prophylactic.
Okay. So I disagree with this answer of the audience. So I think if the straightforward case of hyperbilirubinemia day 3 requiring blood exchange transfusion, so there's no role of antibiotics or prophylactic antibiotics in such a scenario. Whereas the first case, I agree. Fourth case, PT per arm, definitely antibiotics would be good. And we will discuss later on, why they come. So, scenario 6, 34-weeker, 2 kg baby presenting with shock and poor efforts on day 4 of life. Antibiotic, yes or no? So, preterm baby developed shock, poor respiratory efforts, day 4.
A couple of years.
Okay, yeah. So again, this baby is so sick that it may die. So nobody will take a risk that I would not give antibiotics. So you should definitely initiate antibiotics and later on decide based on the investigation and results. Okay, last scenario. Scenario number 7. So this is a preterm 1.5 kg baby who is on ventilator for severe RDS, did not get surfactant. But by day 5 is very stable, minimum support, FiO2 to 25, minimal pressures. And somebody had sent a endotracheal aspirate for some reason. And that has grown Klebsiella pneumoniae, which is sensitive only to meropenem. So antibiotics, yes or no? Scenario 7.
Yes.
Okay. Any no's?
Till now, only yes.
Oh my God. Okay.
Only yes, sir, till now.
Okay. So again, I disagree with this answer, whatever answer that comes so far. So we are not going to treat endotracheal aspirates or, these are colonizers. And again, I will talk about it a little later on. So these are common scenarios and common practices. So some of the practices I think we agreed upon, or majority of them. But in a couple of scenarios, we did not agree upon. Okay, now I want to spend maybe 5 minutes on this so-called sepsis screen or septic screen, if some people call it, because I think this is the commonly used tests in most of the NICUs. Now, I'm not going to in too many details, but few salient points which I want to highlight. So I hope most of you would be aware that how these different markers, the biomarkers, or inflammatory marker, we call them, or the rapid tests, which we are using, how they kind of vary in their quantification in the timeline. So timeline, I mean, once a pathogen enters the body, so the body will start to respond. And suppose 0 is the time when the pathogen entered. And this is the bar showing you the clinical picture that initially there may be signs of SIRS, then maybe sepsis, severe sepsis, septic shock, and so on. So you can look at the example of, let's say, these dotted lines. So this is interleukin 6. So as you can see, interleukin 6 is one of the earliest markers to rise, but also then drops pretty rapidly. And by 24 hours, actually, it has come down significantly, and by 48 hours, maybe towards normal. If you look at CRP, so this dotted line, so CRP begins to rise after 12 hours or so, and only by 24 hours, there are some significant levels, and then it peaks around 48 hours or so, and then starts to decline. PCT, or procalcitonin, as you can see, rises earlier than CRP, and peaks earlier, but then begins to fall earlier also. So suppose you were to do so what it means is that depending on the timeline, that when you are performing the test, and obviously you are performing the test either when the patient comes to you or when you pick up the signs and symptoms. You have no idea, when the bacteria actually entered the body. There's no way to know. We rely only on the signs and symptoms. So depending on when the bacteria actually entered and when you picked up the patient, the performance of the test could vary, right? So I hope this is understandable, that if you were to do the test pretty early on, then CRP may be negative. Or very late, then again CRP may be negative or procal may be negative. If you do very early, interleukin 6 is going to be positive, but later on it is going to be negative. So this diagram has to be kept in mind whenever you are sending or interpreting the rapid diagnostic test. Now, one slide each on the CRP and procalcitonin, because these are the two most commonly used tests we do. So CRP, as I said, rises within 10 to 12 hours. The peak is reached around 36 to 48 hours. And hence, it is actually unreliable for the so-called early diagnosis. And we have to also remember several non-infectious maternal as well as neonatal conditions can increase CRP. I mean, you list any perinatal condition and you will find evidence that it can increase CRP levels in the first 72 hours of life. And definitely, if you were to measure serially, quantitatively, your sensitivity of the test will increase, negative predictive value will increase. So people have shown it may be a useful way of monitoring response to antibiotics, provided your CRP measurement, which you are doing quantitatively, is being done by a very standard method of nephellometry, which is not easily available. So it is more useful for ruling out sepsis, which means if it is negative, you can be confident patient possibly does not have sepsis, and you can stop antibiotics. However, if it's positive, it does not rule in sepsis. And to my mind, it is the most widely abused test in neonatology. The other very popular inflammatory biomarker these days is procalcitonin. And the companies who manufacture these kits or machines would come and tell us, this is much better than CRP, superior, it can differentiate between bacterial and viral, and so on. So again, you have to remember the timeline, what I showed you. People believe it is down-regulated in viral infections, so hence it is a marker which can differentiate viral versus bacterial, unlike CRP. I don't agree with that completely, and I think we have seen during COVID that procal also was raised in several patients, even in absence of bacterial infection. So it rises earlier than CRP, peaks also earlier, so it may be more sensitive if you knew when the bacteria entered the body. And again, like CRP, serial measurements will increase the sensitivity, and people have done studies and shown that if you do serial measurements, you can possibly shorten the duration of antibiotics. And the sensitivity specificity are around 80%, but then with a wide confidence interval. What is relevant whenever we are reading reports of these inflammatory markers, look for positive likelihood ratio and negative likelihood ratio in the report, and not only sensitivity and specificity. Because the sensitivity depends also on the prevalence of the underlying disease. So if you have a population where there is a high prevalence of infection, the results will be different, versus if you are doing the same test in a population with a low prevalence. To interpret PLR, positive likelihood ratio, and negative likelihood ratio, but I generally believe that if positive likelihood ratio is more than 10, then the test is very good. And if the negative likelihood ratio is less than 0.1, then it's a very good test. Otherwise, it's not so good test. So as you can see, the PLR for procalcitonin is 3.2 for early onset sepsis, 7.7 for late onset sepsis. So which means it's better for late onset sepsis, however, still does not cross 10. So it's not a great test. Negative likelihood ratio is 0.3 for early onset and 0.11 for late onset. So which means for late onset, it's a very good test for ruling out sepsis. And although the numbers may be different, but they are almost similar for CRP. So just a comparison of procalcitonin and CRP. This is a systematic review looking at several studies. So basically what you will see that the sensitivity and specificity of both is almost same. One study may claim one to be superior over the other, but if you look at the confidence intervals, then procal may be a shade better, but however, more or less, they are same. And in general, in the early onset sepsis, these tests perform very poorly. As you can see, the sensitivity ranges from 66 to maybe 70-odd%, whereas in late onset sepsis, they perform much better. And if you do these tests quantitatively serially, then they will perform much better. So always a correlation with clinical findings is required for decision making. So my summary of these rapid diagnostic tests will be that they are useful only in situations where your decision about giving or withholding antibiotics cannot be taken confidently. If clinically you think I am going to give antibiotics irrespective of the test results, then better not to do the test. For example, this baby with shock, right? Or a mother with PPROM and baby is symptomatic and baby is preterm. So in these two scenarios, I am going to give antibiotics unless my culture is sterile. So why do the RDT? On the other hand, if I have a baby who has, let's say, a couple of apneic episodes, but otherwise is very active, circulation is good, and I am not sure if he has infection or he does not have infection. So that is a scenario where I will do this test, and if it's negative, then I would withhold the antibiotic. And no single test can claim to be the best, so we have to perform combination of tests, and these screens are useful to rule out sepsis rather than rule in sepsis. So when your test is negative, we can be confident that we have ruled out sepsis. If it is positive, all we can say we are unable to rule out sepsis. It does not confirm the diagnosis of sepsis. For that, we have to rely on the culture. So we can argue that the villain which is preventing our rational antibiotic therapy is actually the sepsis or the so-called septic screen, which we all keep doing, and then which is blurring our thinking and causing problems. But who is the director? The director is actually all of us, because we are the ones who are sending these tests and then having a lot of confusion. So while doing the test, we have to think beforehand how this is going to help me. Is it going to resolve my dilemma, or is it going to create more confusion? So just to again reinforce, and hopefully all of you are aware of these two resource materials, the clinical practice guidelines by NNF, which are available on website as well as Android and the iOS apps. And there is a evidence-based guideline for the diagnosis and management of sepsis, which is pretty recent. And I would suggest all of you go through. It has all the evidence profiled and the reasoning why a particular recommendation has been made. And the second resource material is on the ICMR website, as well as again in the form of apps, which is a standard treatment workflow for sepsis in the neonates, one pager, and which is very simple, which is doable in all scenarios, even without, with limited laboratory facilities. So both are recent, up-to-date, and evidence-based. And I would just like to quote these two recommendations from the clinical practice guideline about the rapid diagnostic test. So the guidelines group suggests not to use serum CRP routinely for the diagnosis of sepsis in neonates with suspected late onset sepsis. However, in level 2 units, because we have several special SNCUs or some facilities where the blood culture may not be available. So the group suggests using serum CRP as a screening tool to rule out sepsis in neonates who have a low probability of late onset sepsis. So I gave an example of newborn with apneas, maybe feed intolerance, or maybe only tachypnea. So in those scenarios, you could use CRP to rule out sepsis. And the guideline group suggests there is no advantage in using the more expensive procalcitonin over CRP as the screening test for late onset sepsis. In early onset sepsis, these tests have no role actually. So coming back to the story of the rational antibiotic therapy. So why is it that clinicians often continue antibiotics in spite of culture being negative and so on? So it's often because we think patient is too sick. So baby was very sick to begin with, although baby has improved, but I can't take risks, so I will continue. This belief that the blood culture often comes sterile in my setup, in my experience. People say, in my experience, blood culture is positive only in 5%, 10%. So they think these are falsely negative. So I think we need to get away from that. Our microbiology colleagues are fairly efficient, especially these days with their back-tech and all, they can give the results fast. And it is, understood because clinical signs and symptoms are overlapping for all the disorders. So naturally, if we send blood culture in 100 babies, we cannot expect all cultures to be positive. So they will be positive in maybe 10%, 15%, at the most 20%. There is difficulty in distinguishing between infection and colonization or contamination. So I gave you the example of endotracheal tube aspirates. So if you were to send routine endotracheal aspirates in intubated babies every day in your unit, you will find after 3 or 4 days, all of them are going to be colonized by whatever bacteria or fungi are there in your unit. So that does not mean they are infected. And then I already elaborated on the use of acute phase reactants. And often the units may not have clear protocols or guidelines. Different consultants may give different verdicts. So there's a lot of confusion. And these confusions are more likely in the preterm, very low birth weight, or ventilated babies for obvious reasons. So as clinicians, as good practitioners, what you can do? So you should practice what we call as mindful antibiotic therapy. These days we always talk of mindfulness in everything. So antibiotic therapy also has to be mindful. So when you're going to start, think and document what is the indication, which antibiotic I want to start. And at the time of starting, you should commit to an exit plan. Okay, I'm starting for this indication. So my stopping plan is this. And document in the file. And every day you see the baby, or whosoever sees the baby, should review that decision, review the baby, and question whether I need to continue the antibiotics or can I exit. Send appropriate investigations and culture. So sending blood culture before initiation of antibiotic or before any upgradation of antibiotic is mandatory. And always think and discuss with your colleagues, senior, junior, nurses, this gives you more confidence whether I can stop antibiotic or not. So I will just run through some of the interventions. I mean, there are several interventions which can be done to, enhance this practice. But I will touch upon some which are easy to do and all of you can practice. So first is the antibiotic timeouts. That is a review at 48 hours after initiation, when the blood culture results are usually available. And you also have the benefit of hindsight. So in last 48 hours, how did the baby behave? What is the clinical course? And what is the culture? So based on all that, you can decide now whether to continue antibiotic or to discontinue. So we call it antibiotic review at 48 hours. If you're a big unit, resourceful unit, you can have system of pre-authorization or prospective audits, which means, the higher generation antibiotics can be prescribed only if, let's say, a senior faculty member or consultant will allow it, or maybe a pharmacologist will allow it. So that depends if you have that system. But antibiotic review can be done by each and every one of us. So when you do this review, the key question to ask are, does this patient have a bacterial infection that will respond to antibiotics? Is patient getting the right drug, dose and route? And if I have to continue, can I de-escalate? Can I, come down? And then if I have to continue, how long more I want to give the antibiotics? So this is an example of our own antimicrobial review chart in our unit. So when we prescribe antibiotics, we use this form where we write the indication also, and we document whether blood culture was sent before starting. And then after every 2 days, there is a review column. So people are forced to write that, okay, what is the review decision, whether I'm stopping, whether I will review again after 48 hours, or whether I'm going to continue, then continue for how many days. If you have a pharmacy support, which is usually not there in our country, but maybe some of the corporates may have, you can have systems of automatic alerts driven by the pharmacy. So they can tell you, okay, these drugs may interact, or this is duplicate, or sometimes, we get 2 antibiotics with the same spectrum, so which has no purpose. So they can warn you about that. They can warn you about dose, etc. So since most of us do not have pharmacy, so what we try to do is on our own during rounds, we try to check these things. One practice which is very useful and we have been following in our unit for, I think, more than 2 decades now, that we have a multidisciplinary antibiotic round with the microbiologists, the clinical pharmacologists, and the nurses. Sometimes we are able to involve the family, usually not so much, but then if we can involve family, that's also great. But definitely, whatever people are available amongst these categories. So if you all sit down together, discuss the antibiotic therapy of each and every baby on a periodic basis, that helps us to rationalize, stop in many babies, change to more rational combination many babies, and also gives us confidence and learning from what we did in the last week. You can also look at in specific treatments. For example, in your unit, if you find a lot of VAP is being diagnosed, and hence antibiotics are being given. So you can review, okay, how we are diagnosing VAP. Is our diagnostic criteria uniformly applied? Is it being interpreted appropriately? Similarly for UTI, or sometimes we are suspecting staph. So many people would empirically start vancomycin, saying that because we have a methicillin resistance available. But then if 50% are sensitive, then why not use oxacillin or cefazolin rather than vancomycin? Similarly, people try to use prophylactically antifungal, saying that we have given broad spectrum antibiotics now at a high risk of fungus. Okay, but then what is your baseline prevalence? So all these can be looked at, periodically reviewed, audited, and you can decide how we can improve further on these issues. So again, a thought for you that you can think and type in your chat box. This answer we can discuss at the end. That what are the challenges you face while you want to practice rational antibiotic therapy? Because knowledge is, all of you are knowledgeable. But in real life, we have difficulties if you want to implement. So you can write down in chat box that why do you think you're unable to practice what we know already? Now, even if we were to start antibiotics in spite of, because many babies definitely would need antibiotics. So the next kind of goal is that, okay, I'm giving antibiotics, but can I minimize the exposure or the duration of antibiotics? So standard guidelines are available, all empirical, but then again, very rational. That, for example, in category of potential sepsis, where you are simply unable to rule out, most people would stop as soon as the overnight culture or 48-hour culture is sterile. If you are giving a perioperative prophylaxis, then typically it is a couple of doses or at the most 24 hours. In clinical sepsis, where your cultures are sterile, most people would be happy to give only for 3 to 5 days. Some people want 7 days, and they are basing, this decision on clinical signs, radiology, sometimes lab. So the duration varies from 3 to 5 to 7, but shorter, the better it is. And once we have a pathogenic bacteria grown, which means the microbiologically confirmed blood culture positive sepsis, then the duration is from 7 to 10 to 14 days. These days, most of us believe that simple gram-negative, uncomplicated sepsis can be treated with 7 to 10 days of antibiotics, whereas Staphylococcus aureus or complicated sepsis would require a longer duration of therapy. So some key good practices which you can adopt or try to adopt, which can help you to rationalize your antibiotic therapy. So one is always drawing appropriate blood culture with appropriate blood volume prior to initiation of antibiotic and collecting the overnight report as well as 48-hour report. Because of the challenge of getting enough blood volumes, we like to use pediatric blood culture bottles where we need only 1 ml of blood volume, unlike the adult culture bottles. And if you have access to BACTEC or similar systems, then obviously you will get much faster reports. Documenting the indication of starting or upgrading of antibiotics in the patient case record is again a good practice. And writing an exit plan, or if you're not exiting, then a review plan. Okay, we'll review after 48 hours. And I've already highlighted the importance of review every 48 hours if you're continuing antibiotic in spite of culture being negative. And please do not treat CBC, CRP, ProCal, or X-ray or endotracheal culture. Treat the patient as a whole. Often people say my procal is high, or platelets are low, or X-rays showing me shadows. I think if you show a chest X-ray to 10 different pediatricians, neonatologists, or even radiologists, all 10 are going to give you a different opinion on that. So very, very misleading, unless you're looking at a gross consolidation, that's different. But the so-called infiltrates or opacities, I think they are so misleading. And do not treat colonization or contamination. It's good to have a written antibiotic policy so that all doctors, nurses in the unit are able to follow that. So it can be consensus-based within the unit, so that it's clear when would we give antibiotics, what antibiotics for how much duration. And although when we start empiric antibiotics, we start broad spectrum, but as soon as culture is available, we must use a targeted approach and use the narrowest spectrum single antibiotic. And based on sensitivity profile, we must try to downgrade to the lower generation antibiotics, and always audit your culture and sensitivity pattern on a regular basis. But I think the real key for antibiotic stewardship is infection control practices. Because giving antibiotics is costly, it is dangerous, and people give justification, our nursery is crowded, we work in a government setup with a lot of overcrowding, a limited number of nurses, doctors, so difficult to practice infection control. So let us give antibiotics and give the most potent antibiotics. So I think that cannot be really justified. So focus on hand hygiene, clean surfaces, clean environment, and aseptic non-touch techniques for all procedures. I think we know it, and all of us know it very well. But if you audit and observe around you, then obviously our practices have a lot of scope for improvement. So what will happen if you don't follow this? What is the problem if you continue the way we are continuing right now? The first is that our patients will obviously be colonized with multi-drug resistant bacteria, and due to that, infections, complications, mortality, and I showed you the side effects. And we see it day in and day out, and we, all of us agree to it, I think. But we also need to remember that we ourselves are colonized with these bacteria when we work in the nursery. Whatever hand hygiene you may practice, howsoever precautions you may take, if we were to do surveillance cultures from our body sites, body cavities, we are definitely carrying these bacteria. So we carry these bacteria home to our family members, they get colonized, all of us lose our useful microbiome, and later on in our older lives, we might be prone to this non-communicable diseases that I listed. So when you prescribe antibiotic, you are actually not prescribing for the individual. You are actually prescribing for the whole society. So if we are not concerned about patients, at least we should be concerned about ourselves and our families. So my plea to you is to do each and everything in your power, and you have a lot of power, to try to rationalize the antibiotics which you use, minimize their use, use the laboratory tests very, very, rationally, and rely on culture and the microbiology. Thank you very much. I think this was my last slide. I'll be happy to take any questions and comments.
Thank you, sir. Thank you very much for very simple but very exclusive and to the basics, clearly giving the indications what to do to everyone. There are a lot of discussions has been going on in the group, and a lot of questions are there, sir. So there are a few comments and few questions. I will just go through queries by the people. People have asked, IT
your voice is
isn't it useful?
Mohit, your voice is kind of wavering.
Your voice is breaking. Yeah.
So now, it is coming?
Yeah, better.
Yeah. So, sir, somebody is asking, is IT ratio, isn't it useful? IT ratio?
Yeah. So see, all these are useful in one way, that they can be indirect indicators of sepsis. And we say, okay, if your immature neutrophil ratio is more than 20-25%, band cells are prominent, so this can be an indicator of sepsis. But this has very low sensitivity, difficult to perform. And again, as I said, these are all non-specific. Let's say baby with perinatal asphyxia. There also you will have a lot of release of immature cells. So they can tell you the possibility of sepsis, but I don't think they confirm the diagnosis of sepsis. And hence our decision to continue antibiotics should not depend on.
Sir, there is a question by Dr. Jaipal. He is asking, there is a confusion that CRP may be of use in late onset sepsis. While in one slide you mentioned not to use if it's late onset sepsis like LOS like apnea. Like he has been getting confused whether to use CRP as a tool to diagnose or take action in late onset sepsis or not.
Okay, so let me clarify. So when I mentioned about apnea example, what I was trying to convey, forget about CRP, ProCal at the moment. Just think of in what scenario I should do any kind of sepsis screen, whatever parameter you want to use. So sepsis screen is to be used in the situation when you look at the baby clinically and you think, I'm not sure is the baby having sepsis or not having sepsis. And one example I gave was, okay, baby has 1 or 2 mild apneic episodes. But if you look at the baby, is very active, crying, feeding, tolerating feed, circulation is good. And it might as well be apnea of prematurity. But you are not sure. So you say, okay, I will do a sepsis screen to rule out sepsis. Or another scenario can be, okay, there are a couple of times baby had feed intolerance. So mild abdominal distension, but clinically otherwise baby is active, circulation is good, no setting for infection. You are not confident enough. So you say, okay, maybe I will do a screen to rule out sepsis. But if you have a baby who presents to you with shock, gasping, having massive pulmonary hemorrhage, getting intubated straight away. So nobody in the world would take a risk, would definitely start antibiotics. So in this scenario, there is no role of doing a sepsis screen. So that is one part. The second part is when you do the sepsis screen, which test to do? CRP, ProCal, IT ratio, etc. So there one message is no single test alone is good enough. You have to do a combination of tests. Number 2 message is in early onset sepsis, which means within the first 48 to 72 hours of life, these tests are virtually useless because of the perinatal stress and perinatal events which lead to alteration in these values. So you cannot really interpret CRP, procalcitonin in first 72 hours. You have to look at nomograms. Even then you are not very confident. Whereas baby, where you're thinking of sepsis after 72 hours of life, and you're not sure there between CRP and ProCal, to my mind, as per the systematic review, there's nothing much to choose. So I hope I've not made you more confused, but this is what I was trying to say.
Sir, there is one more question by Sumit Goel. He is asking what to do if septic. Hello?
Yeah.
Yeah. Sumit Goel is asking what to do if septic screen is negative, but blood culture shows Staph hominis and the baby is asymptomatic.
Okay. So Staph hominis basically means coagulase negative Staph aureus, and we know cons is a common contaminant, especially if you're using a very sensitive blood culture system like Bactalert, because they are able to pick up these. However, we also know that these can be pathogenic in immunocompromised babies or immunocompromised patients. So typically what we practice is, if baby is clinically unwell, so what we do, we take another blood culture and start the antibiotic targeted towards Staph hominis based on sensitivity. But if the repeat cultures come sterile, then we discontinue. But in your scenario, as you listed, baby is clinically fine. So we would not jump to initiation of antibiotics targeting Staph hominis. But we would possibly, most of us would send another culture just to document so that, we are safe as far as, documentation is concerned.
So the same question on culture. If the repeat culture after 7 days is showing the same organism. How long to continue antibiotic?
Okay. The duration of therapy in a culture positive scenario right now is actually empirical. When I said 7 to 10 to 14 days, it is empirical. We do not have real hardcore evidence. There is an ongoing trial, 7 versus 14 days, which has been going on for last 5 years. We still have not been able to finish it. But if your repeat culture is positive, then obviously with the same organism, you presume it's an ongoing septicemia with the same pathogen. What you then have to wonder is why the baby is not responding if your antibiotic is really sensitive. So the typical thing we would look for is, okay, what is the quality of antibiotics? Often these days there's the issue of generic versus branded, and often quality may not be good enough. Is the dose which is going is correct or not? The method of administration, for example, carbapenems, we know they have to be given as an infusion over a couple of hours. Are we using that? And then the fourth thing I can think of is, could there be a complication of sepsis, which means within the body, is there a site which is harboring these pathogens? For example, there could be a abscess development within the abdomen, lungs, or brain, anywhere. So I would like to do maybe ultrasounds. Maybe there is a UTI. So try to look for complications. Otherwise, in any other scenario, sensitive antibiotics should be able to sterilize the blood culture, typically by 48 to 72 hours. In Staph aureus, it can take sometimes 5 to 7 days. Okay.
Sir, there is like Dr. Ronak wants a few comments of yours on one, fumigation. Number two, regarding the how often we should do the audit, and the empirical use of antifungals. Three things, sir: fumigation, empirical use of antifungal, and how frequently you prefer to audit. These three things.
So fumigation, straight away answer is no. There's no role of fumigation of any NICU or any ICU or any OT. Traditionally, the fumigation used to be done with formaldehyde. These days, we use generally this Eco Shield or that peroxides, which are done within 4 hours. We call it fogging, actually, we call it, rather than fumigation. And OTs, etc., it's commonly done. However, scientifically, if you go, then there is no role of it. What is definitely important is thorough cleaning of the environmental cleaning of the unit. So which means in day-to-day practice, you need to have clear protocols of what all in your environment will be cleaned and how many times a day. Whether it is floor mopping, whether it's wall tile cleaning, whether it's your incubator or ventilator cleaning, ambu bag cleaning. So you should have a clearly well-defined protocol. If you're doing that, then you will not need the fogging, fumigation, etc. However, in a scenario, sometimes we land up with so-called epidemics, that you find too many babies are getting infected with same organisms, where definitely we would have to close down the unit, move these babies to some other area. Then yes, you can do fogging, etc. after thorough cleaning. But simply fogging every periodically, that's not required. Antifungals as prophylactic agents. Usually, whatever reviews, systematic reviews, evidence is available says if your baseline prevalence is more than 10% in your unit, then there is a role of using prophylactic fluconazole in a fixed kind of schedule for a fixed duration in a specific group of babies at high risk, generally less than a kilo or so. But if you are not finding too many fungi in your blood cultures, and again, keep in mind the routine blood culture which we send, it's good enough to grow Candida. So all our Candida will grow in the routine blood culture. So if you are not finding up 10% or more, then there is no role of using prophylactic protein. And the third one was about?
So molecular screening. Audit. How often?
Frequency of audits. Okay. So that all depends on the size of your unit, the number of patients you have, the number of cultures you get positive, and your size of your team and the resources available. Right. So it all depends on that. If you are very good, I would suggest do it weekly. And when I'm saying weekly, means you're looking at the cultures, that how many cultures we sent, how many were positive, what were the organisms, what was the sensitivity profile, and what antibiotics we used in the last week for how much duration. But most of us will not have that much time and resources. So typically, we may end up doing monthly also. In our unit, when we do this multidisciplinary antibiotic round, which we do every week, we actually review every week with the microbiologist and clinical pharmacologist. So it all depends on your setup, your resources, how many cultures are coming positive. If you're lucky, very occasional culture positive, maybe you can do it less frequently. But whatever periodicity you decide must be pre-decided. It should not be like, let's do today and then we forget about for next 2 months. So have a plan. In our unit, this is how we will do with this periodicity.
So, is there any like positivity rate of the blood cultures? Like in our unit, specifically, what we have seen is, even though ours is a referral unit, it's outborn unit. So most of the babies when we receive, they are mostly on antibiotic. Our culture positivity rate of vector is around 12 to 15%, not more than that. And that we have seen all throughout the year. And we try to compare it with the national data also, the data which has been available in Indian studies. So it is almost the similar kind of this thing. So is it like if you get higher positivity rate, you audit more frequently, or like is there any cutoff for the positivity rate percentage?
Yeah, so there's no cutoff as such, but in most units, you will find that roughly the culture positivity will be in that range what you mentioned. So anywhere from 10% to 20%. So suppose you say my culture positivity is 35%. So then possibly what is happening is either all the patients which are coming to you are coming very late. Maybe they're coming in shock, septic shock, and naturally a larger proportion is going to be positive. Or I am missing. I may be not sending cultures in babies who have milder symptoms. Because many units don't send cultures uniformly. They think if baby is very sick, let me send culture. If baby is less sick, they give antibiotics, still don't send culture. Right. So I think it depends, but on an average, 10 to 20%, I think is a number. And you rightly mentioned, in spite of the babies being outborn, being exposed to antibiotics, the BACTEC or BACT alert are able to actually pick up the bacteria because they have these resins which can absorb the antibiotics. And in spite of the antibiotic exposure, they are very good in detecting the organism.
So there is a question on role of molecular screening in future. 2 or 3 people have asked this question.
Yeah, great. So a lot of people are doing work on this, molecular diagnostic tests for several years. There is a PCR-based test for a conserved 16S RNA. Then people have found specific genes, and nowadays there are companies which sell this, multi-organism panels that you can put your sample and it will give you a whole profile of what all PCRs are positive, bacteria, virus, fungus also. But we are not sure about the clinical utility of these tests at the moment. The challenge with PCR or DNA-based tests is that even in dead bacteria, this DNA will be picked up by these tests. So this picking up of the organism based on DNA does not necessarily tell us they're actively multiplying bacteria. So that is the problem with these tests at the moment. So nobody is using them as the gold standard. But yes, people are working to refine these systems, work out, and possibly in future, we definitely would need something, or maybe we would have something which can be, DNA based, which is rapidly available, rapid turnaround, but which is also, reliable enough. People are also working on, artificial intelligence, machine learning, and I think you must have heard a great lecture in the Learning from Legend series. But all that is in future. So unless we have something robust, at the moment, we cannot rely on this.
So there is a question by Dr. Somchikar sir. how common are viral infections which can cause sepsis and can be missed? Many units do start antivirals also.
Excellent question. Excellent question. I think viral infections are definitely common. And, there's no reason when you talk of, a child or adult presenting with symptoms, then we say it's viral. So why newborns can't have viral or mothers can't have viral? So it's simply that enough investigations have never been carried out. And whatever limited investigations are available have been difficult to perform or interpret. Unfortunately, for most viruses as of now, there are no specific treatment is available except for a couple of them. So we definitely, for example, if you have a baby presenting with seizures, meningitis, we often would, screen for HSV because we know we can treat. And these days, whenever somebody presents with ARDS kind of thing, we would screen for the, this H1N1 because we have an antiviral agent. So I think viruses are kind of underdiagnosed, recognized, but it's not easy to investigate also. Because suppose you do find a virus, now how do we say this is the one actually causing the symptoms and signs? So need some more research in this area.
So this question by Dr. Urvi Sanjay, actually this question, I don't know if it has come with copy and paste the full question. The question is basically, I think it is that IVF pregnancies, if the babies are born, so is it indication or should we use the IV antibiotics?
It's IV fluid, Mohit bhai.
Yeah?
If the child is on IV fluid, should the antibiotics be given? IV fluid. Yeah.
Okay.
Not
IV
the
fluid.
IVF.
Okay.
Yeah, this is what I was just confused about. What it is.
So straightforward answer is no. I made one statement that there's no role of prophylactic antibiotics in any newborn, whether preterm or whatever, except in the perioperative situation when there is a major surgery. And I would again recommend there is another clinical practice guideline by NNF on antibiotic stewardship, which came this year. And in that, there is an evidence review about specific question that is there any role of prophylactic antibiotics in various scenarios? And evidence review is also available. And the uniform outcome of that was that there is no role of antibiotics in these scenarios.
Sir, a last question maybe. You have shown a graph of CRP, prolactin, PCT, everything. Somebody is asking on YouTube that the vertical lines which were shown, they were due to medical interventions or they decline on their own?
Vertical line I showed.
I mean, in graphs it was shown. I mean, duration in between the vertical lines.
Okay. No. So this is the net kind of, this is not due to treatment. This is the natural response of the body. So this is an immunogenic response. So when you introduce a pathogen, this is how body will respond different because there are different, pathways, the chain reaction. So once the pathway at one place has done its work, then the next pathway is stimulated and so on. Of course, if there's an ongoing inflammation, ongoing multiplication of pathogen, then this may change. So this is not from real patient, but this is the natural course in case you introduce the pathogen and how body responds.
And there were a few comments also, sir, regarding yours. Like slides were very good, very nice presentation, and very clear-cut messages you have given. So few of the doctors, they were like writing these comments also. They were there.
Thank you so much.
So I think so. We should stop here. It's almost 4:43 now.
Thank you so much. I think this was a very, very learned audience. And
thank you so much. Actually, sir, we learned that we should have kept this as a Zoom meeting only because there were more than 200 participants total on all platforms. So next time for lesson from experts, Somsekhar sir, we will be keeping a regular Zoom only because people are there and when you ask a question, there is a delay which can be prevented.
Yeah, I think this is a better interaction.
Yeah. And second, sir, many are asking that can we get the slides? Usually what happens is we are sending the slides as a PDF to participants. So if you can just give us, we can just convert it into PDF and we'll send to all the participants.
I'll email you. You can forward. Sure.
Yeah. So thank you so much. Chagnik, can I have the screen of certificate now?
Yes, sir. Yes, sir.
So Thank you so much, sir. It was really a wonderful talk. We crossed 1 hour, 15 minutes, but then it was really so many questions were still there. But then, yes, it was such a wide topic. So NNF Gujarat is lucky to have you in our first month of this new year. So certificate of appreciation is presented to Dr. Praveen Kumar sir for being an expert in neonatal Pathshala. The lesson from experts, rational antibiotic therapy, NNF Gujarat State Chapter, 25th January 2023.
Thank you. Thank you.
We are also thankful to Dr. Mohit Sani for moderating the session and being there with us. So thank you so much. Everyone can join on Neonatal Pathshala. Same ClearNet link, same YouTube link every Wednesday between 3:30 to 4:30. We promise to start sharp at 3:30 and we always start at 3:30. Sometimes we overshoot due to interesting topics, but then that is how the education goes. So thank you so much, everyone. See you in next Wednesday in PG case presentation. So we will be meeting in that. Thank you so much.
Thank you. Bye-bye.
Thank you. Thank you, sir. Bye bye.
Thank you very
Thank you,
much.
everyone. Thank you, everyone, sir.
Sagni, we can end the meeting.
Okay, okay, sir.